Hello, my name is Adam Rule, and it's my pleasure to present work that I've been doing with colleagues at Oregon Health and Science University, looking at the tools clinicians leverage in electronic health records to help them write clinical notes. While I'll be talking about a particular tool used in a particular context, my hope is to help paint a picture of how clinicians increasingly use programming to write clinical notes. To lay some groundwork, let me start with a scenario. This is Samantha. She's an ophthalmologist, that is an eye doctor, and it's her clinic day. That means it's one of the days where she sees patients, and she'll have 15-minute appointments every hour for 8 hours across the day so that she'll see 24 patients in a typical clinic day. Now that's a lot of patients to see, and so Samantha often enlists the help of technicians, nurses, and scribes to help with particular parts of the visits, like rooming patients or performing routine eye exams. However, on top of this clinic load, Samantha also has a documentation load where for each patient she needs to write a note that's used as a legal record of what occurred during that visit, that's used for billing and reimbursement of services provided during that visit, and is also a communicative document to help her either talk to her future self or to other clinicians taking care of this patient down the road about what happened during the visit. Now, this is a lot of documentation to generate, and many clinicians like Samantha are now relying on tools in their electronic health records to help them document at scale. One of the tools that clinicians are increasingly using is copy-paste or copy-forward. That is, they can look at the note that they had written for this patient's last visit and copy some or all of that into the note for the patient's current visit and edit from there. Another tool clinicians increasingly use is templates, where they can have boilerplate text and data from the record automatically imported into a template note that they can then edit. And on top of that, many clinicians are now using a team-based documentation model where they get scribes or nurses or technicians to start the note for them, to pull in some of the standard data that might go in that note. And they can edit it later with their clinical reasoning and their plan for care. Now, each of these tools is really helpful in saving clinicians time and maintaining some consistency in how they document. But using them also has side effects that have been discussed widely in the clinical literature. One of those is note bloat, where clinicians increasingly report the feeling that the notes that they use to document care have gotten longer and less informative. What I'm showing here is a typical note for ophthalmology, that is eye doctors, in our context at Oregon Health and Science University. It's 4 pages long, and much of the note is actually bulleted list or tables of information like medications or the patient's problem list, which may not be all that relevant for the particular visit being documented here. A related problem is that of note redundancy, that is, of text not changing between notes, and so new notes being not all that informative. For example, if we look at this current note and say how much of the text in this note can we find in the note for the patient's previous visit, we find that actually 3/4 of the text is exactly the same across the notes used to document these 2 visits, and only 1/4 of the text is really new and maybe all that informative. So there's some side effects to using these documentation aids. And in fact, there have been a number of studies looking at how it is that providers use copy forward and copying of the notes. However, what I'll focus on in this study, and what has been less studied, is looking at how providers use note templates or collaborate with members of their team to generate documentation. And in particular, I want to talk about a type of note template known by many as dot phrases. So going back to our scenario with Samantha documenting patient care, let's say she's working on this particular note, and she's already written into the note her assessment of the patient's cataracts, cloudiness in the lens of their eye, and her plan to follow up with the patient in the future about this care. Now she's at a part of the note that's typically known as the chief complaint, just a 1-sentence summary of who the patient is and why they're here today. Now, she can go to different parts of the record, look up the spelling for the patient's name, copy it into this section, or she can use a dot phrase. And in this case, one that's typed period, one-liner. So you can see dot phrase, often used to refer to the syntax of these phrases starting with a period. And when she hits enter after typing this phrase, the medical record will look up the specification of that phrase, including these kind of bolded data links that will then pull in data from the record and then interpolate that data with the boilerplate text to put a blob of text into the notes. Now, if you were to go and ask just a random clinician on the street, odds are they would say, yes, I'm familiar with dot phrases, or I even use them widely in my practice, but we have very little data about how they're being used. So my colleagues and I sought to provide a little bit of evidence by asking, how is it that dot phrases are used, at least in our context, to document ophthalmology visits, eye doctor visits at Oregon Health and Science University? More specifically, we were interested in things like, what do these phrases typically look like? Are they kind of used to build up a note section by section, as we showed before? Or are providers dropping in an entire note all at once? How often are these being used? Are they used every visit or just rarely? Who creates these phrases? Is it hospital or department administrators who create a single phrase or a single template for the entire department to use? Or are providers creating them, or even staff members creating their own? Who invokes or calls these functions and these phrases? Is it mostly providers, or are they delegating to their staff members to use them to generate notes? And lastly, what impact is this having on documentation? And in particular, how much of a final note can we attribute and say came from using one of these dot phrases? In order to get evidence to answer some of these questions, we examined dot phrase use in the ophthalmology department at Oregon Health and Science University across 2 years. We pulled EHR metadata on the dot phrase use, and we looked at this metadata for 48 different providers and the hundreds of staff who worked with them. This covered about 200,000 outpatient visits, and in the end, about 5,000 unique dot phrases that were used over 600,000 times across those 200,000 visits. So about an average of 3 of these phrases being used each visit. Now, to our first question, what do these even look like? When we manually coded all 5,000 unique phrases, we found really 3 broad categories. The first are what we're calling helper phrases. And I'm showing an example here, .va, which becomes the text visual acuity. These really didn't pull in any data from the record. They just saved typing a few keystrokes for phrases like visual acuity that providers write over and over again. A second type of phrase that we saw really commonly was an attestation or signature phrase. And this is really more of a workflow phrase. When a provider has written a note, or their staff members or technician has put in a portion of text in the note, they need to then sign and say, I attest that this portion of the note that I just edited is correct. So after editing it, a technician or a provider might use a phrase like this to drop in a phrase that say, I, technician so-and-so, or provider so-and-so, attest that this information is correct. Lastly, one of the most widely used categories of phrases we saw were really full note templates. As opposed to the example before, where you might build up a note section by section, what we actually saw was wide use of these full note templates that would use dozens of these data links embedded in boilerplate headers and text to generate a near complete note all at once that the provider can then go in and edit manually to put in things like their assessment and plan. So these were the 3 broad types that we saw, but how often were they used? Well, when we looked across the 200,000 visits that our data set was covering, we found that over 80% of those visits ended up using one of these full note templates. Somebody, whether a staff member or the provider, had invoked one of these phrases while generating the note. Less common was use of these attestations or signature phrases, or the helper phrases, which were only used in about 50% of visits. But if we just say, what percent of visits had any type of phrase used at some point when writing the note, that's about 95%, which is the vast majority of visits. And in fact, when we looked at those 5% of visits that didn't have one of these dot phrases used while documenting, we found often these were short stubs of notes, things like patient didn't show today, that weren't the typical documentation flow. One other interesting thing we were looking at is customization of phrases, who created them. And what we found is that almost 3/4 of the phrases that providers ended up invoking while writing notes were ones they had created or customized. So it wasn't the case that they just got one from an administrator or even used a default one built into the medical record. They had created and customized the phrase. Now, this was different for staff members, whereas staff members, only 41% of the time when they invoked a phrase was that phrase one they had created. More often, it seemed the case that they were using phrases made by other people, administrators, or the providers that they worked with. Now, we also looked more specifically at these full note templates and found that there was a lot of customization with those types of phrases. And in fact, 1 out of every 3 providers, so that would be 16 out of the 48 providers in our data set, had a full note template that they used and their staff used, but no one else used. They weren't sharing it across other providers who maybe saw similar cases. Now, moving on from customization of the phrases, we looked at who actually invoked these phrases, and we found that providers and staff invoke them to varying degrees. So if we look across all phrases, most of the time, 58% of the time, it was a provider who had invoked and called that phrase to help generate the note. But this differs drastically by the type of phrase. So for example, for those full note templates, more often it was the staff member who was invoking that, whereas for the short helper phrases, more often it was the provider invoking that. So we begin to see this workflow between this data and the customization data that shows maybe providers creating a custom template, but then having their staff member be the one to invoke it during a visit to help generate a template note, and then the provider going in and using helper phrases later as they fill out the assessment plan with details of the particular patient's case. Lastly, we were able to use some metadata to find that dot phrases and the data links buried in them account for most of note text. So when we look here, we estimate that 70% of text in the typical note is coming from these dot phrases, and only 30% is either copied in or manually added. We can break that down further and say almost half of the note, 43%, is being populated by data links, bringing in things like medication lists, problem lists, and about a quarter of the note is this boilerplate headers that you might see in these phrases. Now, we've shown a fair amount of data about the use of dot phrases in one context, and you might rightly be left asking, so what? Providers use note templates. Is that really all that insightful? And I think there's a couple of discussion points or implications both for practice and researchers coming out of this work. For practice, it shows maybe where some of this note bloat and redundancy is coming from. If so much of the note, up to 70% in our particular context, is being generated by these dot phrases and templates, maybe when we're trying to address note bloat and note redundancy, we should be looking at the design of those phrases and coaching administrators and providers on phrase design, note template design, while still giving them the tools and power to customize and localize those templates for their particular clinic. On the research side, I think it's interesting to note how this data begins to show how providers are using programming to write clinical notes, and particularly end-user programming, which has been differentiated as the process of programming primarily for personal benefit rather than widespread public use. So providers creating these templates for their own use and those by their staff members, but not really for others. Now, as soon as you begin to think of clinical documentation as a practice of programming, I think it leads to a number of other implications. One is the thought that these dot phrases and the embedded data links are really application programming interfaces. And we might want to think about best practices for APIs and how to structure and guide use of these dot phrases. So for example, encouraging naming conventions or verb action first naming on the name of these dot phrases, providing clearer documentation so providers can search for existing phrases that have been created by other people. Currently, that's very difficult to do in many electronic health records. Or providing developer tools to scaffold and guide providers as they create these phrases, noting where there might be some sources of redundancy or redundant data links that are just going to pull in the same data twice in a single template. For researchers, I think this particular study begs the question of how we might develop programming paradigms that let providers leverage the power of both narrative and structured text in the same document, in the way that data scientists are beginning to use computational notebooks to have narrative and interactive data analyses in the same document. Might there be more that we can do to support providers working with both narrative text and clinical data in the same document? Here at the end, I want to thank all of my colleagues in the Ophthalmic Informatics Lab at Oregon Health and Science University, particularly Michelle Hribar and Michael Chiang, my advisors. And with that, thank you all for listening. I hope this has been at least somewhat thought-provoking for you. Thank you.